very good afternoon to one and all. GEM Hospital Chennai proudly welcomes you all to the scientific program session on pelvic floor disorders. Following the grand inaugural ceremony that we had today morning at our center, it was imperative to have a broad discussion on the problems that constitute the pelvic floor disorders and the diverse modalities of treatment that our multidisciplinary specialist unit has to offer. In this regard, we have organized a series of informative lectures and video presentations today. We are also live streaming on Facebook and GEM Televersity for the benefit of all. And we are happy to announce that we have sent an invite to more than 10,000 surgeons. So, without further ado, I would like to welcome our first speaker for the day, Dr. T. Shrikala Prasad Madam, a very eminent and renowned urogynecologist and laparoscopic surgeon who needs no introduction, with a rich experience in urologic surgeries and gynecologic surgeries, working as the professor of urology at Chengalpet Medical College. We welcome you, ma'am, today, and we are very happy to have you here today. I would call upon ma'am to deliver a lecture on overview of pelvic floor disorders in women.
Good afternoon, one and all. At the outset, I would like to thank our chairman and the entire team of GEM Hospital for having conceived this idea of a clinic for pelvic floor disorders, which is really a wanting specialty by itself. And thanks to the entire team for making it occur. So, without much ado, we'll just go into the subject. So, there are a lot of things which we deal with pelvic floor disorders. The main issues are with urinary incontinence, pelvic organ prolapse, and fecal incontinence. This is one of my favorite slides showing a tip of the iceberg. I still see a lot of patients who have been suffering for years together and have not come out openly with the complaint of urinary incontinence. So I would request all clinicians to ask leading questions about the issue of incontinence. There is a gross underreporting. There are a lot of factors. First of all, patients are ashamed. They don't want to come out in the open. And I see they get advice from a lot of doctors saying that it is part of aging. Like that, there is a delay and there is a gross underreporting, and there are lots and lots of women who are suffering and who actually can be helped. So, why are we worried about urinary incontinence? It is not only the psychosocial aspects like the intense embarrassment, loss of self-esteem, feeling of helplessness, social isolation, depression, anxiety, work impairment, economic costs, and affecting quality of life and physical discomfort. What is more worrisome is the fear of falls and fractures, which can make it potentially debilitating. See, we are really not worried if a woman leaks a few drops of urine on stress. But imagine an elderly, obese, or osteoarthritic, diabetic, hypertensive woman who rushes to the toilet if she wants to protect herself from a urgency and urge incontinence, and in the bargain sustains a fracture neck of femur. Her whole life changes with this. So we are worried about them. If you talk about incontinence, it's a whole subspecialty by itself. We have different kinds like stress, which leaks with conditions of raised intra-abdominal pressure. We have our urologist talking to us exclusively on that. Urgency and urge incontinence, and many patients having mixed, overflow, functional, transient, lots and lots. So, what are we going to do? Like all other specialties, A comprehensive medical history is what is very important. A pertinent physical examination, urine analysis, and other investigations go a long way. So, here the duration of the leak is very important, which guides us to what the problem is. For example, she says she had a difficult delivery and she leaked 10 days. We are going to think of VVF. She had a hysterectomy, either an open or a laparoscopy, and had leak about 10 days. We would definitely like to think of a cause which is related to the surgery. And similarly, the history the patient gives, that I leak when I cough, laugh, and sneeze, and rest of the time I'm absolutely normal. She's suffering from stress incontinence. If a lady says, the moment I think that I need to pass urine, I have that urgent desire to pass urine, I'm not able to hold it till I reach the toilet. This is what we call an urgency urinary incontinence, and many of them have mixed it. And we need to know whether the amount of leak is trivial or is it significant, or what we call as the bothersome score. Does it really worry them? You know, a leak of a few drops of urine, we are not going to be bothered. But every day if she's going to soak her dress and it makes her life very miserable, then definitely it's a matter of great concern. And when we have a lot of cost constraints, are we going to do a urodynamic evaluation for all? Maybe we can, if cost constraints are a matter, we can think of intrinsic sphincter deficiency in people who give a history saying that with trivial stress itself, I have a marked leak. That is, they just do this clearing the throat and they leak terribly. They are suffering from ISD. And so my treatment towards that will be in that direction. My colleague will be talking to you that. Similarly, if they give a history that vehicular jerks also they leak, I think of a pointer towards an ISD. And we are all extremely good at taking a good obstetric gynec history, and especially looking for any evidence of an abnormal bleeding, a postmenopausal bleeding, because many a times I've seen women coming with an advanced CA cervix, malignancy infiltrating, causing a malignant VVF, where they've never had a bleeding through the vagina. This was the presenting feature. So we should never orient ourselves only to the urinary problem, but take a complete history. And one of our problems is constipation. I'm going to talk about that, though we have our rectal colleague talking on that. And medication list. Most of the women who suffer from urinary incontinence are elderly. We do see people, younger people also having, but that goes into another group. They have a lot of neurological factors, other things which needs to be evaluated. But by and large, the vast majority are the elderly people, where they are suffering from a lot of comorbids and have a lot of diseases, lot of drugs. So it's very essential that we have a look into their medication list and go about. The next thing is the bladder diary, which will also come. And this I showed multiple comorbid systems, and which we got to really take up. And drugs. Again, I have a whole lot of drugs which can affect the urinary system. And in part of our history, we should know how the voiding is, how they are able to pass urine. Is there any obstruction, say difficulty in passing urine, needs to strain, intermittency, hesitancy? Think of an obstructive cause. It could be an overflow incontinence. So in this patient, we are not going to put a tape. We have to find out what the problem is and then treat. And similarly, is there any irritative symptom? Believe me, a patient with an irritative symptom, frequency, urgency, dysuria, they also have little leak. Just give that leak a little, push it aside and evaluate for these causes of frequency, urgency, and dysuria, because that symptom is never going to be all right with your management of an SUI. So before you label them as one SUI, please look into other things, because they can really take your life out. And also, like whether the stream fluctuates and do they need to push or strain. For example, people with procedentia will tell that they push in the uterus to pass. So all these things can be good pointers, and certain red flags are there. Any hematuria, we are really worried, has to be evaluated. Has there been any lower urinary tract instrumentation? Is there any accompanying neurological symptoms like numbness, tingling, etc.? All these needs to be taken care of. And similarly, as part of evaluation, We want to know whether they are premenopausal, postmenopausal, how is their estrogenic status, etc. And surgical history, I told you we are very good at that. We take a very good history. More important is whether they have had an anti-incontinence procedure earlier, because we still see a lot of people putting a midurethral stent because it's little easy to put, and then they come back with recurrence. Probably they were not evaluated earlier. So these patients, like I will tell later on, they require urodynamics, and whether there is any neurological injury like in APR, etc. And a detailed history, childhood, adolescence, neurologic history. Is it a neurogenic bladder? What we are concerned. And again, time and again, I want to reinforce this factor that diabetes mellitus, we are the diabetic capital of the world, and we see a lots and lots of patients with frequency, urgency, etc. because of the uncontrolled diabetes. Similarly, a patient with diabetes can have voiding dysfunction, can have an autonomic cystopathy, or they can have incomplete voiding because the bladder does not generate powers. So especially if you're dealing with a diabetic person, please beware and have that in mind, and you need to know what is their dead reserve function. Similarly, radiation, neurologic, urologic trauma, etc. And then when we evaluate the patient, I told you we need to evaluate totally. So the mobility, the mental status, the drugs, and the impact of incontinence on the patient and the caregiver. What is their behavior? What is their bothersome score? How much does it affect them? And in geriatric practice, the urgency, etc., this factor, what is the accessibility of the toilets and lighting? So there are people who try to cut down on cost by switching off the lights, especially if you have elderly people at home. Try to have at least a dim light which will show them where their toilet is, so that they don't sustain falls and fractures and are able to reach the toilet in time. Physical examination, again, to this vast crowd I don't need to talk about how to examine an abdomen, but a distended bladder is what is more important. It could be a manifestation of either a difficulty in passing an obstruction or a neurologic that they are not able to empty, inability to empty, a neurogenic cause. So the treatment differs whether you have to relieve the obstruction or you have to think in terms of neurogenic. And similarly, looking in for a urogenital atrophy, vulval excoriation, cystocele, rectocele. And if you are looking in for a pelvic organ prolapse, it has to be examined in the empty bladder as well as in the full bladder to look for evidence of stress leak, as well as examine the patient with the bladder with the prolapse inside as well as outside, so that you also look in for any occult incontinence. Another point which I want to reinforce is rectal examination is very, very important. It gives us a lot of information, like it tells us about the bulbocavernous reflex, which absent can be a marker of a neurogenic disease. The sphincteric tone. When we talk about fecal incontinence, more than other neurologic causes, what we see in day-to-day practice is the obstetric anal sphincter injuries. So that also, believe me, I've seen people suffering for 10 years because they do not know that it is curable. The persons whom they have gone, if they are not aware of the possible treatment, may just pass it off. So we still see a lot of people with a long drawn duration of a fecal incontinence, and look for rectal prolapse, rectal mass, stool impaction. Stool impaction is again a very important cause of voiding dysfunction, especially in the two extremes of age, the pediatric as well as geriatric. So we need to evaluate and look for fecal impaction and the ways by which we can control that. Again, this, I think this previous slide was a bladder diary. It is gone. That's okay. A bladder diary will tell us how much of fluid they are taking at what time and what time they are passing. So it will give us an idea as to how much they are taking, what is the urinary frequency, what is the functional volume. All those details we will be able to get. And similarly, they can mark the time as to when they had incontinence, either with the urgency or with screening. Okay. Then, so this is another point, no? Before we decide on doing something really important. We have to assess the degree of bother and the desire for treatment. Determine the impact that the leakage has on the patient's daily life and activities, and does the incontinence limit the individual's activities? Has she made lifestyle changes because of the threat of leakage? There are many people who do this toilet mapping. Before they go for a shop, almost all women will empty the bladder, but they will look into where the toilets are. If they go into a mall, they will know at this end there is a toilet. So that toilet mapping is there. Or are they using underpads regularly? Are they using diapers to protect themselves? How severe is their the treatment? And investigations, everybody knows. I want to emphasize on, when you do an ultrasound, please also look for a post-void residue. So a significant post-void residue tells us two things. One, there could be obstruction, or two, there could be incomplete evacuation because the bladder is not generating powers. Cystoscopy, do we do for every incontinence? No. Only for those who have hematuria. I was talking about red flags, or if you are suspecting some pelvic mass, or if it is a, again, you think of any mass there. Similarly, urodynamics we don't do routinely, as well as if it is a simple, straightforward case of a stress incontinence. So when all do? You can do when you think that there is, most important is a redo. A patient has already had and is coming. So previous surgeries, or you think it is a neurogenic bladder, or there is a mismatch between signs and symptoms, it's mandatory that we do a urodynamic evaluation. When we talk of the whole concept of a pelvic floor disorders, these all take real impact. That is lifestyle management, fluid management, caffeine reduction, etc. Other dietary irritants. We'll just go one by one. We have a lot of people saying, if they, they have some urinary difficulty, they say thanni nariya kudi. So that itself, excessive fluid intake can be a problem with their frequency urgency, or because they are afraid of leaking, they don't take fluids. So inadequate fluid intake can lead to dehydration, UTI, constipation, and decrease the functional capacity of the bladder. Then dietary irritants. Caffeine, other irritants are sugar substitutes, citrus fruits, highly spiced foods, and tomato products. See, what irritates one person may not irritate the other person. So we tell them to maintain a food and beverage diary and stop what irritates them. We need not give a blanket list saying molaga, takkali, everything. Don't cut down anything. Give them the freedom to choose based on their own food and beverage diary. This is one of my real passion when I treat voiding dysfunction and one of the pelvic floor disorders is fecal impaction. This fecal impaction, I don't know whether I am trespassing my rectal colleague, this acts like a space occupying lesion and can obstruct normal voiding. Because of this mass, constipated mass, it causes incomplete bladder emptying and can even cause an overflow incontinence, and can also, this mass like thing will promote involuntary detrusor contractions. So not only that you have to tell them that they have to take lot of fluid as well as fiber diet. Both are extremely essential, and you have to teach a lot of self-care practices that promote bladder regularity. So ensuring adequate dietary fiber and fluids to ensure normal capacity, and reinforcing to them that sufficient fluid intake is also equally necessary for fiber supplementation to be effective. And especially in the geriatric population, we have to encourage them for regular exercise. And we have seen that teaching them that they can use the regular time for bowel evacuation. Many people have that postprandial bowel movement. So you can tell them there is nothing wrong, that they have that habit of going and sitting in the toilet after food. And they can do the self-care practices. Some people try stimulating on the anus and somehow let them have the habit. If they have a habit of timely passage of motion, that the stools don't get harder and harder and they land up in fissure pain, again that promotes constipation. So this has to be a dedicated effort. So even in our government hospital, we have my staff nurses also who talk to them on this. It needs time and effort. Only then we will be able to take care of this. This and pelvic floor muscle treatment depends not only on the doctor. You have a good support person, even if it is a staff nurse or some worker who is trained in that, it goes a long way in that. And obesity, loss of 5 to 10% of body weight sustained for a 12-month period can reduce the incontinence. And even if it doesn't reduce, it can make the patient fit for anesthesia. Similarly, reducing smoking and looking into those reversible factors like you control sugar, the hyperglycemia, polyuria decreases, keep them fit, cardiac, hypertensive, COPD, everything we contract. This pelvic floor muscle training, again we have a dedicated session on the biomedical, biofeedback, etc. In KGH, we started a trial like, we gave sticker bindis to the patients. We asked them to stick it on their dressing table, on the fridge and on the stove and the mobile, etc. So that when we found what was a factor which was impeding them for exercises, one, they don't have time, including us, they don't have time, two, they forget. So we incorporated this into their daily acts of work, and we taught the government hospital poor uneducated patients. We found that this definitely improved their doing the exercise. So training of pelvic floor muscle with intent to improve, I will leave that because we're going to talk that. And we regularly don't use routine pereniometry or electrical stimulation. We don't go for biofeedback. We only do this kind of pelvic floor muscle training. I'm fortunate to have very good staff nurses, though I moved out of KGH. My KGH staff nurses were extremely good at training and teaching them, that they even do a vaginal examination and see that they correctly squeeze the muscles and teach them to do. So you need dedication and care to ensure that pelvic floor muscle training was done. And in our practice, we did not see much of an effort in the postmenopausal women. Other than that, in a younger age group, we did see a lot of effort. So I am a person who really believes in weight reduction and pelvic floor muscle training. This pelvic floor muscle training will take a long time to get effective. So we teach them to brace or do the knack. What does that means? See, they know they're going to cough. They know they're going to strain or squeeze. So at that moment, they have to do the pelvic floor muscle. You ask them to squeeze, contract and lift the pelvic floor muscle. At that time, they can prevent a leak. So this goes a long way in ensuring that they do the exercises. Though to make them do it regularly is a little job, but really, believe me, takes a lot of dedicated effort. So we have more number of physiotherapists in our country, more number of gynecologists than we have physiotherapists. So we should double up in that role unless we have somebody to support us. So these were the reminders I was talking you. And the another thing is a bladder training. நம்ம ஊரில் என்ன சொல்லுவாங்கன்னா ஆத்திரத்தை அடக்குனாலும் மூத்திரத்தை அடக்காத. So that was the habit that, whenever they wanted to pass urine, they go and pass urine. Like that, they keep on going till they reduce the functional bladder capacity. So we teach them based on their bladder diary. You look into the bladder diary. If they have been passing urine every half an hour, you ask them at the first desire of passing urine to sit down and do the exercise. And this will go, see that it will come in waves. And if they do the contraction, they will be able to, that desire to void will pass off. They will be able to hold urine for some more time. So a person who was passing urine every 30 minutes, we used to encourage them to do this exercise and do it for 45 minutes. Another 1 week later, we used to make them do it at 1 hour. Then again, 1 hour, 15 minutes, like that. So it's a very useful first line treatment. But in our population, if I only tell this bladder training, the acceptance rate was found to be less. So addition of anticholinergics were very, very useful, and this also goes really a long way in helping. So I'm not going to cover about stress incontinence. So overactive, the thing is the frequency, nocturia and urgency. So they have a reduced time from first sensation of urgency to voiding and reduced volume per void. I am scared of this lady. I am scared of the obese, diabetic, elderly, osteoarthritic who rushes to the toilet and sustains falls and fractures. So anybody who says urgency has to be really taken care of, and all the multimodal management which I'm talking. So how do you do? The first slide, I think it is going a little bit this side. What I have written is evaluate and treat all causes of increased urinary frequency. Time and again, I have seen patients being referred to me as urgency, urge incontinence, and my first sugar examination will show as 450. Believe me, diabetes is a very high number we are seeing. So don't forget about the other causes. So a simple examination and screening, we will be able to detect. Then level 1, conservative measures, pelvic floor muscle training, weight reduction, really goes a long way, really goes a long way. Then they don't improve, go on to anticholinergics. We have a whole lot of drugs, oxybutynin, tolterodine, solifenacin, darifenacin, trospium, and a new kid on the block is mirabegron. So you can try all these drugs, and if still we don't gain improvement, is what I am talking about, botulinum toxin, sacral neuromodulation, and percutaneous nerve stimulation. But believe me, I have never had to go to that level at all. We will be able to make our patients all right with this. And certain small tidbits in these drugs, choose any drug, almost all the drugs are equally effective, and start from the lowest recommended dose, and if it's effective and well treatable, just maintain that, no need to change. And bladder bladder training, the evidences, that is we are talking about evidence-based medicine. Bladder training and pelvic floor muscle training and conservative measures are in no way inferior to the drugs. So we can really go ahead, but only thing is it needs a lot of dedication and a good support person other than you also, that go a long way. And complaints, if you see our people taking drugs, I give solifenacin, the number of times they take or the long drawn is less. So we have problem with compliance also. So it's better to involve everything. And we are worried about cognition. All these drugs are effective in elderly, and cognitive function is not affected by the drugs which we regularly use. And there was a study in the Urological Society of India about the prescribing patterns of urologists. So they have found that the common drug used by a vast majority of the people was solifenacin and mirabegron. So generally we try and start with solifenacin 5 mg, and if you don't get improvement, you can increase it to 10 or add with mirabegron of 25 or increase it to 50. And this combination was found to have was very efficacious and found to have less side effects. Estrogen, we don't give systemic estrogens, we give topical vaginal estrogens for women with postmenopausal symptoms and atrophic vaginitis. They don't improve, we go in for botulinum toxin, sacral nerve stimulation, posterior tibial nerve stimulation, etc. I just put this point because we have had patients who came with frequency, urgency, and almost frequency amounting to incontinence. We go back in her history, she was telling that she went to a doctor and they gave her Norflox and a Citralcan. She was taking that, and again she took that for 4-5 times, and then again she went to another doctor and they took all the same thing again and again. So she would have seen the doctor for 2-3 times but taken the tablet same medication for nearly 25-30 times, till she came to us with frequency amounting to incontinence. So what was it? Was the bladder had almost shrunken to like a thimble bladder, end stage tuberculous cystitis. What her presentation of frequency urgency was not urinary tract infection or not the one which needed norfloxacin. I am not blaming norfloxacin. We have to evaluate and find out what the condition was. So in our country, we do see lot of tuberculosis, genitourinary tuberculosis. So if the patient has frequency urgency, we also have to think of that mind. And when the bladder almost comes to a thimble bladder, she would need something like an augmentation cystoplasty. And I told you, like, people don't come with only urge or only stress. Most of them have both together. So how do we treat? If stress is more than urge, I tell my postgraduates, remember S for S, stress, treat surgically. If it is urgency, we treat with medical line of management. And for elderly, though I have seen people coming and saying it's part of aging, we know that there is a definite increase in the incidence of incontinence with elderly. We should know that it is not incurable. They can be evaluated and treated. And when you take a care for the elderly, you should avoid bladder irritants like caffeine, tea, and soda. Keep the pathways clear and bathrooms clutter-free with light at all times. And make sure you provide regular bathroom breaks. The attender has to be taught to empty the bladder at least 3 to 3.5 hours and not ignore them for a long time. And use underwear that is easy to remove and to get on and off. Use absorbent underclothes for trips away from home. Most important, it is very good to have a supportive caregiver. And when you see elderly person suffering from nocturnal enuresis, what we have to remember is it a manifestation of obstruction? Is prostate the reason? Or do they have an underactivity or an overactivity? So, or is it a neurogenic? So, instead of blaming persons for bedwetting, we have to evaluate what their cause is. Then, drugs. So we can treat them with drugs, but we like desmopressin and avoid in elderly patients having cardiovascular diseases or hypertension, and hyponatremia should be watched for. Our simple alarms which we were treating young children with nocturnal enuresis is useful. Trying to reduce the fluid intake before bedtime and giving alarms is also very useful apart from drugs. And if the patient also has overactive bladder, we can add anticholinergics. The other thing is overflow incontinence. That is, there has been a mechanical obstruction which was missed, and hence, it's overflowing. So again, we should know what were the causes. Is it an obstruction or a neurogenic? In women, what are the obstruction? It could be a gynec malignancy, it could be a fibroid, it could be an ovarian cyst, it could be fecal impaction, it could be an urethral obstruction, stricture, or a prolapse. Or you can have hypotonic causes, diabetes, and like these interrupting their spines, tumor, herniated disc, etc. And what are the transient incontinence? Involuntary loss commonly seen in elderly patients during an acute illness. Transient incontinence should improve with the resolution of the underlying medical condition which triggered it in the first place. So you have mnemonics like diapers, delirium infection, atrophic vaginitis, pharmaceuticals, etc. Or now they use it as drip, a condensed version. A functional is a person is usually aware of the need to urinate, but for one or more physical or mental reasons, they are unable to get to a bathroom. So that could be because of confusion, dementia, poor eyesight, impaired mobility, dexterity, or unwillingness to use a toilet due to depression or anxiety. So with all this, our ultimate aim should be to make an incontinent lady as a continent. That is our aim. And our aim should be to cure incontinence, keep the patient comfortable, prevent discomfort, prevent complications. In case we are not able to make them better with all these things, advising them on the use of diapers also is not a shame. So that should also be as part of our management. And to this group, I don't have to talk about how a pelvic organ prolapse, how it has difficulty in passing urine, white discharge, backache, etc. But I would just highlight on certain points. When we have a big procedentia, please ensure that the ureters are not dragged. You don't have a significant hydroureteronephrosis or a significant post-void residue. If there is a significant dragging on the uterus, almost to the point of elevation of their creatinine, it is better to put them on a pessary for some time, reduce edema and reduce the dilatation, and then take up. Similarly, we see a lot of patients with long-standing anemia. There is no need to give blood transfusion to correct this prolapse where there is no ongoing blood loss. You can put up pessary and treat them with iron and then take them up for surgery. So certain small tidbits. Again, global prolapse we see with a rectal prolapse also, where we do a combination procedure along and make them all right. And we see a lot of decubitus ulcer. I think I have one more slide which shows, can you see a small decubitus ulcer? Whereas this is a long drawn prolapse which looks like a, scary malignant ulcer. So if this ulcer is really scary, you can take a biopsy, also put in a pessary, and if there is no malignancy, it heals well, and then you can take up for the regular surgery, or else they will require oncological procedures. Just by looking, you would think of it is a pelvic organ prolapse. It's a vault prolapse. And then again, this is also a vault prolapse. I was actually trying to point out that uterosacral dimple on both sides, showing which is the anterior compartment and which is the posterior compartment. And this picture, I don't know whether you're able to see, this had the same patient, this had a large enterocele. So the moment I opened out, the entire colon was coming out. So when you evaluate also, we have to see whether there's a possibility of an enterocele. Like certain factors, we see that if it's a cystocele, you will see it thick because there's a bladder underneath. But if it's an enterocele, the vaginal wall will be very thin because directly the peritoneum is lying. And we must be ready to treat it. You open the hernial sac, reduce the contents, and do a high ligation of peritoneum along with the cystocele repair. So overall, a good history taking, methodical evaluation, appropriate management, positive attitude, and an environmental manipulation, we are going to have a best outcomes. I think I've been able to cover the maximum. There are any questions I would take up, or at the end, whatever you want. Thank you.
That was a very beautiful presentation. A lot of practical points on a rather broad topic. I'm sure a lot of women in the audience would be enlightened after this talk. So next I would like to call upon Dr. Rajashekaran Siddhan sir, a senior consultant and lead urologist at GEM Hospital, Chennai, to deliver his talk on the management of stress urinary incontinence.
Very good afternoon to all of you. I'm sure all of you will be very enlightened with the extensive talk and the wonderful practical explanations given by Dr. Srikala Madam. I'm going to My name is Dr. Rajashekaran Siddhan. I'm a senior urologist at GEM Hospital here in Chennai. So at the moment, this is where I work, GEM Hospital in Chennai, and then I trained in urology mostly in the United Kingdom. Underwent the training there and spent a few years of being a consultant there and moved here. This is where my training was most of the time there, the University Hospitals of Coventry and Warwickshire. Of course, before going there, my alma mater, where I did my MBBS, was Stanley Medical College. And of course, this will bring a lot of nostalgic moments for a few doctors around. What I'm going to talk here today is about stress urinary incontinence, which is a small portion of the talk given by Dr. Srikala Prasad. As you all know, it's basically urine leakage. It can be both in women and in men. I'm going to be concentrating on the women today, as it will be too extensive to cover both men and women in one talk. It may take a few days. So today's talk will be mostly about the stress urinary incontinence in women. How do we define stress urinary incontinence? It's basically involuntary loss of urine through the urethra whenever there is exertion, like coughing or sneezing or even laughing and crying. If you have to put it more technical terms, then it's diagnosed using urodynamics. And in those terms, we call it as urodynamic stress incontinence. And that is described in technical terms as having a urine leak whenever there is an increase in abdominal pressure, but without any increase in the detrusor pressure. So we should all know why we don't leak in the first place. God has created a wonderful human body with a very orchestrated function of all the organs and the different body parts. And the mechanism that works here to avoid any urine leak normally is pretty straightforward. What is done is the urethra, the tube that carries the urine out of the bladder to the exterior, is basically a collapsed structure. And it's kept closed all the time, and the mucosal folds are approximated to each other. And we call it a cooptation, where they just stick to it and they don't leak or they don't let any fluid come through. And hormones, of course, play a very important role in maintaining this structure. Next thing what we see is the anatomy of that particular part of the body. Like we've been talking, it's like a hammock in between the pelvic bones. We call this the pelvic floor, which tends to support these organs in a very careful manner, in a way that whenever there's increase in pressure, they don't let the tubes open up and leak. And of course, the neural mechanisms do play a role. Our brain and the spinal cord control the different activities in our body. In the same way it happens here as well. It is an orchestrated function of whenever there's a need to pass urine, the bladder contracts and the urethra opens. But otherwise, it is kept closed by the neurogenic mechanisms. Other combat movements are also available. The way the pelvic floor is designed, it is designed to protect these organs. So why should one leak? So in medical terms, we call it pathophysiology, like to find out the reason why one should leak. So lots of research has been going on in this field. As you all know, it's a very, very embarrassing issue, particularly for women, to come out and complain. At the same time, to put up and live with it is again another very embarrassing thing to do. So this has been a topic of interest for many decades, and lots of research has been done. And we are now in a situation where we could understand how this is happening. And we have arrived at 4 different theories of how this can happen. So these are labeled as urethral hypermobility, malfunctioning of the midurethral complex, intrinsic sphincter deficiency, and of course the last one is a trampoline theory. As you can understand, trampoline is a structure which is used for people in circus, where there's a big net and people jump on it, and this net is held on place by different ropes all around. So that itself will give a brief explanation of, the pelvic floor is like the net between the bones, and that supports the organs which are hanging in between. So that's what the trampoline theory means. So I'm going to talk briefly about the different theories. Before going on to talking about the theories, this is an image which might explain how our pelvic floor is made of. This is an anatomical picture. Excuse me. As you can see, in the front, the pubis is the front part, and that is the bone in the bottommost part of our body, in the abdomen. So from there, we go. So that's the pubis, that's the bone. And behind the bone, till the back, we have the different structures in the pelvis. And the first one being the urine pipe, the urethra. Then in women, we have the vagina. And then behind that comes the rectum and the anal canal. So as you can see here in the red colored picture, this is the pelvic floor. This is formed of a group of muscles, ligaments, which provide a support mechanism to hold these organs in place. So I don't want to go into all technical terms here in the public forum, but these are the structures which form the different parts of the trampoline or the hammock. So in the urethral hypermobility theory, what they're saying is going back to the image, the urethra is here, and the muscle structures here and the ligaments behind, they hold the urethra and they form a back plate where the urethra leans on. So whenever there's an increased pressure, which means there's a pressure from the top coming down, the urethra is pushed back, but this supportive mechanism holds it in place from falling too back and also helps to compress the tube and close. So whenever there is a weakness of these structures and the urethra can move a lot, then as you can see, the opening can be left open and the leakage can happen. So that's the urethral hypermobility theory. So that's what they say in technical terms, the mucofacial layer. That is the name given to the structures there. And the muscles, the endopelvic and the pubocervical fascia and the levator ani muscle, they form a circular pad of muscle sheath, and this acts like a hammock. So any failure to this, of course, opens the urethra, and then you have a leakage of urine. So the second theory which was described was the malfunctioning of the mid-urethral complex. Again, going back to the image, the mid-urethral complex, we call it the upper part, the mid, and the lower part. The mid-urethral complex is down here, and this again you can see it's full of muscles and ligaments structures supporting it. So what they say, whenever there's lack of support here, again the pressure on the top can lead to easy opening of the urethra and leakage of the urine. So any weakness here will lead to stress urinary incontinence. And this again understanding helps us to design the treatment as well. As you can imagine, if we can support this structure, then we can prevent the leak. So intrinsic sphincter deficiencies, basically a sphincter is a mechanism that we have. It's formed of two groups of muscles around the urethra, which is coming out of the bladder, and it keeps the urethra closed all times except for when the brain sends signals through spinal cord for it to open up in order to help pass urine. Other times it's kept closed all the time, and this mechanism has to be tonic in the sense it has to be under complete control all the time and tight enough to hold the urine from leaking. Any problem with this mechanism then tends to leave a lax upper part of the urethra and the bladder neck area. So whenever there's an increase in pressure in the abdomen, it is easy for the urine to leak. So that is what is explained by the intrinsic sphincter deficiency mechanism. And this sort of problems happen in people who have radiation therapy for cancers. So now we know what is stress urinary incontinence and why we don't leak and what can lead to leak. And we are now going to touch base upon what are the risk factors which can lead a person to develop this problem. As Dr. Shrikala has already mentioned, high BMI is a very, very important risk factor to develop this problem. And I'm sure you would have noticed in a talk that by reducing the weight, almost 70% of people tend to get better. So high BMI is a very high risk factor for developing stress urinary incontinence. Obviously, pregnancy and childbirth, as we all can imagine, can put extreme pressure on the pelvic floor muscle structures and make them lax and lead to stress urinary incontinence. Parity is nothing but multiple pregnancies. The same mechanism, when it happens repeatedly, as you can see, it will definitely lead to weakness of the muscle and stress urinary incontinence. Whenever there is a difficult childbirth, again, we have a system where the pressure is sustained high throughout in the pelvic floor area, and that leads to compression and also injuries to the muscle structures, and later on they become lax and lead to stress urinary incontinence. Hormones do play a role, like I mentioned before, in keeping up with the tissues and their estrogenization, we call. The hormone levels drop when lady attains menopause, and that can also contribute to this sort of problems. As mentioned earlier, pelvic radiation therapy can also affect the tissues around the pelvis, and one of them is the urethra, and that can lead to the effect on the sphincter mechanism, leading to intrinsic sphincter deficiency and stress urinary incontinence. Neurological causes are very important factors. As we all know, nerves control all parts of our body. Same happens here. And the orchestrated mechanism of opening of the bladder or bladder neck to release the urine out should initiate the opening of urethra as well. If this happens when the bladder is not supposed to empty the urine, then of course the urine can leak. So this sort of disorganized functioning by the nervous system can also lead to urinary leaks. And obviously previous urethral operations or any operations around that area can lead to laxity, and weakness of the area can lead to the stress urinary incontinence. How can childbirth affect it is an interesting question which the women would like to know. Like I mentioned before, the multiparity, which means the number of children we have, and if it is all through vaginal normal delivery, that puts repeated pressure and it can lead to laxity of the pelvic floor muscle and lead to stress urinary incontinence. Instrumental delivery is when there is any obstruction to the labor, and if there is a difficulty in delivering the child, then the gynecologist will use instruments to help the process. And in that process, there's a chance that the pelvic floor mechanism can be affected. The prolonged second stage is when the baby passes through the vaginal canal, and that is when the pressure around the pelvic floor muscle is high. And if that stage is prolonged due to any reason, then of course there is going to be some effect on the pelvic floor muscles. And the pressure also can lead to nerve damage to the nerves around that area. And obviously, fetus itself, if it is bigger, then it can put extra pressure and lead to further damage to the pelvic floor muscles. So, how do we manage this issue? Stress urinary incontinence, the urine leak whenever there is an increased pressure in the abdomen. So, as Dr. Srikala Prasad has already explained in a very detailed manner about the importance of taking history and clinical examination, I'm not going to go too much in detail into that. So, we need to really know exactly the extent of the problem through the history taking, and also about the severity of the problem and how much it affects them and how much keen they are to get this sorted out. At the same time, a good, thorough clinical examination will give us an idea about the different abnormalities that may be present already and the different pointers which can help us understand what the mechanism could be for the problem of the patient and will help us in the management. Going beyond history and clinical examination, we have to think about the various investigations that is available to assess these patients. This was also touched base on in the previous talk. We start with what we call a uroflow and a post-void residual volume check. This is basically understanding about how good the urine flows through the urethra. So there should be an uninterrupted flow of urine when there is an initiation of micturition happening, and it should develop a good amount of pressure, an adequate pressure for the bladder to empty completely. So this is what we'll be checking in this test about the speed of urine flow and also about urine evacuation, whether it's complete or incomplete. Next thing we got to look for is the testing urine for any infections. Obviously, infection has to be treated. Infection can lead to other effects which can lead to the urinary symptoms as well. Ultrasound plays a very important role in understanding if there is any other pathology going on other than just this problem, or if this is just a indication of other pathologies around, like a mass in the bladder or the urethral area or in the neighboring structures, which can be very helpful in addressing that, which will in turn help solve this problem. The more specific investigation coming to stress urinary incontinence is the bladder diaries. Basically, this is about understanding their problem. We are going to request the patient to help us understand what their routine is. So we'll be giving them an idea about what to record for a short period of time, say 3 to 5 days, instead of giving them a long period. And what we'll be asking them to record is how many times they pass urine a day, and whenever they pass, how much they pass, what sort of fluids they drink, how many times, what times they drink. And all these information will be collected together, and these will help us understand their routine and also the stimulating factors which can lead to the problems and also address the management issues. Different questionnaires are available which will help us understand how much this problem itself is affecting their quality of life and how much is this a botherance, and also about how severe the problem is. So these are very important factors for us to understand as doctors so that we can address the individual patient in their own right. So next specific test going forward would be urodynamic testing. Endoscopy is done not in all patients, and again Dr. Shrikala Prasad Madam has already explained that if there is any red flag signs and any specific indicators for need for endoscopy, then we should consider them and put them through endoscopy to make sure we don't miss any other pathology. Going through to the specific investigation for this stress urinary incontinence, we call this urodynamic evaluation. Urodynamic evaluation is basically, we are going to try and understand how the bladder is functioning. So in a human body, the bladder is designed to hold the urine and also to expel it out. So this is what we are going to try and understand, if this is happening in an orchestrated way. So when the bladder compresses, the urethra has to open up and the urine has to flow out. So if there's any problem in this mechanism, either there is a block in the urethra causing difficulty, or if there is a decreased pressure being developed in the bladder, these are all the factors that we'll be looking for, and this test will be helping us to understand. This is a interventional investigation. So there are strict guidelines about whom to use it on and when not to use it. So we don't jump into urodynamics in every patient. If there is a straightforward stress urinary incontinence patient with a history and a clinical examination, then there won't be a need for a urodynamics of confirmation to proceed for treatment. So we proceed with the treatment for them and carry on without urodynamics. Whereas in situations like when there is a previous urethral surgery or anywhere where you don't understand exactly what's going on, whether it's a mixed incontinence, then we need to have a clarity before treating a condition, and that's when this urodynamics is very useful. So what do we do in urodynamics testing? So in urodynamics testing, basically we start with the uroflowmetry, like I explained before. It's basically assessing the urine flow and also make sure the bladder is emptying well. And next thing is, as I said, it's an interventional procedure. We had to put catheters both in the bladder and also in the rectum, and we measure the pressure changes inside these organs, and this will help us understand the amount of pressure generated by the bladder during various phases of micturition. So going into the phases of micturition, we call cystometrogram, which is a filling phase of the urodynamics testing, where the bladder is assessed about how it reacts to different levels of filling of the bladder. Next thing, we'll be looking for different abnormalities that happens during the cystometrogram. Like we'll be monitoring the pressures both inside the abdomen and also the extrinsic pressure that can be generated onto the bladder by the outside of the bladder from the abdomen itself. Electromyography is another part of urodynamics evaluation, which is not always used in every test. This basically estimates the amount of muscle activity in the pelvic floor, which can help us understand whether there is any functional loss in that area which leads to the problems. Of course, this adds to a very minimal added information which will help us in treatment, so it's not used extensively. So next comes the voiding pressure flow studies. This is done when in the voiding phase, which means when the patient is passing urine. So we assess the way the bladder is functioning during a voiding phase, which means the bladder should contract and expel the urine out. At the same time, the urethra should be opening up to release the urine. So pressures will be adjusted according to this. And if there is any block in the urethra, as you can see, even though the bladder may be pressing to expel the urine may not come out, which means it may develop more pressure, and it will reflect in the urodynamics evaluation as a very high pressure being generated in the bladder. So in this way, we can understand if there is any problem with the urethral opening. So this is just a sample graph of the urodynamics test, and it's quite a complicated test to understand for everybody except for the specialists who deal with this day in and day out. I'm just going to briefly show what represents what. So if we come to the first line, it's basically the flow, which we do before we start the procedure. So it's basically a flat line before the patient starts passing urine. It goes up when the urine is being passed, and then once it's finished, it comes down. This just explains the urine flow pattern. So the second line shows the volume, amount of urine that's being passed, which is being measured and graphed here. The urodynamics evaluation is the last 4 lines. So this one, first one is the PVES. This means vesicle. Basically, this is the pressure which is measured inside the from inside the rectum. So sorry, this is from inside the bladder, but this will be the pressure of both detrusor and the abdominal pressure together. So the catheter inside the bladder measures this pressure. As you can see, the pressure which is generated inside the bladder is generated from both outside and the muscle itself. So this will be the combination of both. The PABD abdomen is the pressure which is generated in the rectum. Here, rectal wall don't have an intrinsic muscle and they don't develop any pressure. So the pressure that's generated here will all be just the abdominal pressure. So what we get by taking off the abdominal pressure from the rectal wall from the vesical pressure will be what the detrusor pressure is. So I know it's quite a bit complicated to understand. It takes a big 1-hour session at least to explain and make people understand what these pressures mean. To put it very short, all that we are trying to understand is if the bladder muscle is working. If it is working, is it working adequately, or is it putting more pressure, or is it developing very less pressure? This is what we are trying to understand from these lines. So in case of stress urinary incontinence, what we tend to do during the cystometrogram, which is the filling phase, is we tend to increase the abdominal pressure by asking the patient to cough. And when that happens, when the particular pressure reaches, here in this graph you can see as there's a small leak which has happened. So at the same time, the detrusor muscle pressure, you can see it is not increased in any way. So actually the bladder muscle is not contracting to push the urine out, but there is urine leakage just because the pressure inside the abdomen has increased. So that is a true stress urinary incontinence. That is diagnosed through the urodynamics. So video urodynamics is another more specialized investigation that we perform in these patients, particularly in selected patients where we expect there could be hypermobility issues or intrinsic sphincter deficiency issues. The whole idea is basically when we fill the bladder with the fluid, we tend to mix some contrast along with the fluid and use a C-arm fluoroscopy to assess the bladder during the filling and also voiding phase. So basically what we get in the report is basically, as you can see in this image, we can see the bladder and the urethra, and because it's filled with fluid with contrast, it is seen very clearly. And whenever there is cough, we can, if there is an intrinsic sphincter deficiency, we can see that very clearly over here, which will be quite open. And when we don't expect any urine to pass through the urethra just by coughing, we will see the contrast going through, and that is a true stress urinary incontinence. So in this way, video urodynamics helps us to understand these specific issues. So once we diagnose stress urinary incontinence and characterize them according to their severity and also the nature of the causative factors, then we got to think about how we treat these patients. So treatment is very broadly divided into conservative and interventional treatments. Conservative measures, our colleague Dr. Shrikala Madam has given a very nice extensive lecture on the conservative measures. And they include, to start with, the fluid management. The amount of fluid you drink and the timing of fluid we drink also matters in the amount of urine production and also the management of same. Hence, fluid management is very important. And the type of fluids, there are quite a few number of irritant fluids which can lead to these urinary incontinence. Hence, we got to identify what are those irritants, and this can be variable. Different people can have different fluids as irritant fluids. So the people have to assess themselves, and we got to guide them and help them understand that. So fluid management is the key. Next thing is lifestyle changes, including dietary changes. Here we again insist upon the BMI. That's very, very important because as we all know that just by reducing the BMI and having a healthy weight, urinary incontinence can be almost corrected in more than 50 to 60% of patients. Next thing is the programmed voiding. We basically help the patients understand about the importance of voiding. We come across people who are very shy and they don't void as much as they should do. And at the same time, there are people who are very impulsive, and whenever they get a small signal or small sensation, they just want to go and void. So they keep on voiding. So both these extremities are not good. So we got to make them understand the ideal system and make them follow a programmed voiding pattern, which will help them settle down into a habit. Next thing, we all know about the pelvic floor muscle training. This basically is to strengthen the pelvic floor muscles, and these exercises are quite specific and quite specialized exercises which we advise that is being supervised and taught by trained physiotherapists to the patient so that they understand exactly what is exercise involved and how to target the pelvic floor muscles and benefit from it. So it has to be supervised exercises. And the guideline says that these exercises, once taught clearly, patient should practice it at least 3 times every day and at least 8 contractions every time. And for this, our madam, Dr. Shikla Prasad, has given a wonderful idea about a trial that she has done with the patients using their sticker bindis to help them remind themselves and also to practice it, which is a wonderful way of reminding them and practicing it in a strict way, as there is very good evidence to say that if the patient practices this pelvic floor muscle training exercises sincerely for up to 12 weeks at least, these are having better outcomes than giving them any medical treatment as such. So we have to insist the importance of pelvic floor muscle training and make them practice it sincerely. Electrical stimulation in case of stress urinary incontinence, it has not been proven to be very beneficial, whereas it has worked in urgency incontinence and urgency symptoms. Next thing is pharmacological treatment. Pharmacological treatment, we have a few drugs which can help with it and has proven to have very mild effects. But of course, these are not having complete or satisfactory results, hence it's not used too much. Of course, tricyclic antidepressants, which has got some neurological controls. Duloxetine is one of the common drugs that we use here, can be used and can be trialed in some people who may be beneficial from it. And obviously, estrogens has been used, and the role of hormones in maintaining the tissues has been discussed. The other measures which can be used other than the common pelvic floor and thing is urethral bulking agents. We use bulking agents to be injected inside the urethral mucosa to bring in some sort of coaptation effect, which can work in selected group of patients. And vaginal support devices have also helped, particularly in patients who have other associated problems like prolapse. We'll go on to the surgical treatment options of stress urinary incontinence. And as I have mentioned before, the reason for stress urinary incontinence has been understood to be a weakness of the pelvic floor. And the pelvic floor has been seen or described as being a trampoline or a hammock. So basically, the surgical treatment options, usually what we think about is trying to strengthen this pelvic floor and the hammock effect by giving them support through a surgery, and so that the urethra is kept in place or it is being supported well in order to avoid any stress urinary leakage. And different types of procedures are suspension procedures and sling procedures. Basically, suspension procedures aim at supporting the urethra by supporting the back plate of it. The paravaginal tissues are being supported by different procedures. We have at least 4 different types of procedures described, out of which the Birch-Calper suspension is a very popular one, and it can be done laparoscopically as well. So basically what we do is, as we see in this image, from inside the abdomen, the doctors will understand that we go have a look at the anterior vaginal wall tissues on either side of the urethra and try to support them and tie them to the inguinal ligament or the pectineal line using sutures to support the urethra. Whenever there's increase in abdominal pressure, they don't have hypermobility issues and the stress urinary incontinence is corrected. So as I mentioned, this can be done laparoscopically. The sling procedures have the same idea of supporting the mid-urethral complex mainly, and this can be done both this is a pubovaginal sling. It can be done in 2 ways. It can be done as a transvaginal tape procedure. I'm not going to go too much into detail of this as it will become more technical. So basically I'll show an image which will explain. So basically what we're trying to do is to pass a tape from the pubic area down to the anterior vaginal wall and below the urethra and try to pull it up like a hammock. So we put a tape from one side to the other side and support the urethra on top. And this has further developed to a transobturator tape procedure where the tape is passed instead of from the suprapubic area, it is passed through the obturator foramen. The main difference was that the chance of bladder injury by doing this procedure was less. But of course, off late, for these mesh procedures, we had a lot of controversies throughout the world because the mesh, it's a polypropylene foreign material to the body, and they have different side effects as well, unless if it is laid properly. So they can erode into the tissues, they can cause infection, they can cause significant pain around the tissues, and can have effect on the day-to-day life. So these things have been assessed very clearly, and the outcome has been explained that the mesh procedures have a wonderful outcome, almost more than 95% success rate. At the same time, it has been acknowledged that yes, these mesh procedures can cause side effects like pain and erosion, and it has been advised that any doctor who practices it should be in a position to explain the procedure in detail to the patient, at the same time explain everything honestly about the side effects possibilities and get the patient on board, and if they are willing 100%, then go ahead and continue with the procedure, as there is a wonderful outcome for these procedures. So thank you all for your patience of listening to all these things. Stress urinary incontinence, like I told you, is a very, very embarrassing issue which has a treatment option which can correct it, is what we are trying to convey a message to all the general public here. And we would like to extend our new pelvic floor department in the service to all the local people who are interested to come and know more about the issues and also know about the different treatment options available. And we are here to help. Thank you very much.
That was a very informative lecture. Thank you very much, sir. We move on to our next talk on dyssynergic defecation by Dr. Sridhar, Senior Consultant Medical Gastroenterologist from GEM Hospital, Coimbatore.
wonderful program, and big congratulations on starting the GEM Pelvic Floor Clinic. So, so let's coming back from urological issues. It was a wonderful talk by the previous two speakers. So, coming back to something basic of all the pelvic floor issues, uh, functional defecation issues is something which is very common in our day-to-day presentation, especially a gastroenterology center like GEM Hospital. So this plays a huge role in the patient's day-to-day functional activity, like the similar uro genital issues which we discussed prior. So when it comes to constipation, it's no more a taboo to talk about constipation. We have movies being made in Indian cinema which makes 150 crores based on a simple topic like constipation. Who have not watched the movie, please do watch. I'm a movie buff, but this is something you can just say how a family gets traumatized by one person's bowel habits. You could see the Innova carrying the whole chair, and that's a commode actually. So the old gentleman here, played by Amitabh Bachchan, actually carries his commode. He says, I cannot pass potty if I don't have the chair, so he carries it. So that's how difficult the issues can be. So let's proceed with the topic. See, what we perceive as a physician as a constipation, they are gonna just say, எனக்கு மோஷன் ஒழுங்கா வரதில்லை சார். They'll just say the movement. That's what is the primary concern of the patient is. They don't really care or are considerate about we are not considerate. We don't ask them about the other issues. There is significant percentage of patients, literally 80% of patients complain of straining. Tamil சொல்லனா முக்கி தான் மோஷன் போறேன் சார். That's what they'll say. Or very few people will say எனக்கு அந்த மோஷன் வந்து கல்லு கல்லா hard lumpy stools. These are the two common presentations rather than the frequency, which goes literally lower down. So in between these two, there is a bunch of symptoms like incomplete evacuation. Stools cannot be passed fully, and most important, something which we always miss is we take abdominal fullness and bloating to be an upper GI symptom rather than low GI symptom too in our OPD practice. So always consider the whole description in toto in these kind of a situation. So when it comes to Indian data on constipation, it's so bizarre because the Rome 4 is here, and which we don't usually even follow in our own OPD practices, and it's been almost shelved to the studies and the epidemiological surveys and things like that. But even when you see the criteria used here, when it comes to self-perception of the patient, they score higher. But when you use criteria in these patients, they tend to get confused and the prevalence tends to very much narrow down. But is this the reality? I would honestly say, scientific data apart, some industry will give you a bigger answer. This industry. The Ayurvedic industry, even our government these days supports Ayush. Same goes to something which is a multi-billion-dollar industry like constipation, plays a clear role. It's a household issue. Let's not fool ourselves saying 10%, 20%. It's 30 to 40%. That's how big is the market. And now with the instance of cancers going up, opioid-induced constipation is something, a bigger issue, which all of us will face in future. So this literally says the instance and household nature of this constipation. But it isn't such simple thing. Constipation is not so simple, like we just said. It's a bothersome thing for the patient as well as for the doctor, trust me. When it comes to a chronic constipation, it can be a primary or a secondary constipation. Secondary constipation can be, leading on as a sequelae of a lot of pre-existing issues. But a primary constipation itself is divided into three. The transit can be a problem, or it can be a normal transit, or it can be a pelvic floor dysfunction. I always tell the patient, why am I getting constipated? I tell them a traffic jam. If it's in Coimbatore, I say Avinashi Road. If it's in Chennai, I say OMR. Unfortunately, where we are located. So it's like that. So sometimes the transit is issue, sometimes the whole gateway is issue. So that's how it's simply put to the patient. So that's how we need to say it. When it comes to the primary constipation, the normal transit, the stool actually passes through the colon in the normal rate. But this results in a persistently difficult passage, including straining, hard, lumpy stools, or an incomplete evacuation. This is a normal transit category. The slow transit category is where the stools take a longer time to reach even the distal colon or the rectum, but there is no identified physiological or physical causes, including a lot of endocrine issues. The pelvic floor dysfunction, which we are trying to target now, is a whole different paradox. This is with regards to the muscles which are used to evacuate the bowel, which are quite inefficient. So even if the transit is normal, but they are still retained in the rectum, resulting in an incomplete evacuation of the rectum or obstruction. The whole list of secondary constipation should also be ruled out. Don't take this, we are digressing from the core issue of dysenergetic defecation. To reach there, you need to go through this. So if this CME is targeted to all the general practitioners out there, and anyone watching this, just pay attention to every word the patient is going to say and dig deeper. I would say dig deeper even to the psychological issues. Depression, eating disorder, sexual abuse, obesity, like how our previous speaker said, urinary incontinence, and all these pelvic issues have a huge role to play with obesity and higher BMI. Previous history of surgeries, labor, pregnancy, everything needs to be taken into account. If you're talking about an elderly, please check their prescriptions. The neurological drugs used for Parkinson's these days, early Parkinson's is quite common, needs to be taken into account, which disturbs the bowel motility and as well as the defecatory functions remarkably. And we are looking at a huge outbreak of, I would say COVID-19 is a pandemic itself, but a silent epidemic of cancer is sweeping our country, and opioids are being used for pain relief in many patients. So drug history is something very remarkably to be taken, and patients on psychiatric medications needs to be focused to. There are a lot of psychiatric medications which cause a slow transit constipation. Metabolic issues is something which anybody in the audience will be very clear about, including dyslipidemia and as well as thyroid and diabetic issues. So when we are talking about the whole issue, we need to be very clear about the red flags. Basically, if it's an unexplained, a short frequency, a short history of bowel movement changes, a palpable lump, presence of persistent bleeding without anal symptoms, an unexplained weight loss or a fever, especially in this COVID scenario, people just brush aside saying it's piles and whatever they want, seeing Dr. Google, it really doesn't, they don't realize the impact because of the misinformation everywhere. So please pay attention to the red flags, and any patient who already self-medicated and they found unresponsive, don't try to switch to an alternate prokinetic or something simple and just rush away. Please do check for the other red flag signs, and we might be actually missing some, and we might be actually saving many. So coming back to the topic, the whole paradigm of functional defecation disorder is something associated with the anorectal dysfunction, which includes dyssynergia or an inadequate defecatory propulsion. From Greek and French Latin, right? So let's take it simple. Texture is easier to remember and to understand. Simple. So rectal pressure increases, anal pressure decreases. So what happens? Somebody is training, this is releasing, stool comes out. This is as simple as that. This is a normal defecatory rectum. This is a manometric picture, by the way. So we'll be jumping between this so that the point is conveyed rather than giving a lecture on the topic per se. So there are various 4 types of defecatory disorders which you see. In everything, something common is there is no negative response. Can you see positive, 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 positive? Anything which grows up is positive in life. So something similar. So in this, the anal sphincter relaxes, right? The sphincteric pressure relaxes here. Let's talk very clearly. Here, whenever the rectal pressure increases or doesn't decrease, the anal pressure persistently remains high. So thereby releasing, there is no defecatory response. Still not clear? Let's get something even more simple. That we have an election finish. Not bringing or teasing anybody. Even though somebody tries anything, if you have a pandemic or a situation like this, your defecation is not going to happen. So whatever you try in the rectal space, if the sphincters and the pelvic floor doesn't function properly, you're not in the race anymore. And hence, the functional defecatory disorder happens. So not trying to hurt any Rajini fans out here, but this is just to give a parallel. So coming back to science and imaging, the whole defecatory mechanism is simple. We tend to push increase in rectal pressure through the abdominal pressure in the rectal side through various mechanisms. In this time, the puborectalis muscle aids, which is a sling around the lower rectum, relaxes and thereby causing this angle, the anorectal angle becomes more obtuse. What is acute? It's something acute, right? So whenever you squeeze, it becomes more acute. When you relax, it becomes more obtuse. Simple. So this is what you're seeing in an MR defecography also. This is in a normal state. This is while on contraction, which becomes acute. This is on relaxation, becomes more acute. Normal is between something between 90 and 110. So more acute, you have a defecated disorder. Colonic transit study is something which is very simple. There are various kits available in India, basically with various measures of capsules and the markers. So basically, presence of markers even after day 5. If 25 capsules are ingested, there are 50 capsule variants also. Whichever is the protocol, if there is a persistent of 5 markers, even 5 markers at the end of 5 days, just keep it simple. So 5 markers, 5 days, think of slow transit study. So all this has to be integrated into a simple topic like constipation. So let's keep it simple. So you have a patient who is a if you have a patient, please do a basic anorectal manometry. If you are suspecting, you've tried, you've treated, you're suspecting a functional defecatory disorder, please do a anorectal manometry. It is quite available in both the centers here. Second, do a balloon expulsion test. It's simple. A 50 ml warm water is injected, the balloon is kept, patient is expelling it, fair enough. Basically, it clearly shows the muscle is relaxing and the whole thing comes out. So, if it becomes abnormal, clear cut, you directly label them as functional defecatory disorder. But when you have a normal response, the pelvic floor is normal, please think of colonic transit. From that, it's clearly visible that sometimes most patients, at least in India, have a remarkable percentage of slow transit constipation if you include it in your diagnostic algorithm. Whenever all these things remain inconclusive, then go for MR defecography. Very few centers in the country has it. Coimbatore, we are fortunate, we have our a friendly institution which we refer the patients to for MR, has the MR defecography and plays a huge role in diagnosing in these inconclusive cases. So, when coming to what is dyssynergic defecation, as per the criteria, even it's not very clear even in Rome 4, even though the types are very clear, patients must satisfy the criteria for functional constipation. There are a lot of patients, before going to this, in this whole bunch of this study, this constipation classification, there is always a mixed pattern. Like India is a diverse, right? So something similar. So it can be a pelvic floor dysfunction coupled with a slow transit, can be a normal transit with the pelvic floor dysfunction. Of all this, an IBS is something which has to be brought into the picture too. So when you think of constipation, think of everything in parallel. So coming back, patient must satisfy at least one of the following criteria, where inability to expel an artificial stool, which is a balloon expulsion test, and inability to evacuate or 50% of variant defecography during the study. A dyssynergic pattern of defecation using the anorectal manometry is also quite crucial. So anything less than 20% relaxation of the anal pressure or an inadequate propulsive pressure at the rectal component, both should be recorded. So this has to be demonstrated in a patient's comfortable environment, and repeated attempts should be done before labeling a patient with dyssynergic defecation. When it comes to the therapeutic part, constipation is something which anybody out here will be very clear. Fiber, fluid, physical activity, and drug therapy. But the buck doesn't stop there. Biofeedback, like how our colleague Dr. Sindhil Kanpati is going to have a lecture on, plays a huge role in these patients in literally retraining the whole pelvic dyssynergia. So when it comes to the whole topic, my little humble request is pay a little more attention and have your algorithm reworked unupdated. Don't take constipation as simple as it is. If we are missing something, it's going to be treated by somebody in open space. It's like Google, anybody can share their thing, it's open source. So let's, as doctors, start revising and revisiting a simple household topic like constipation. Thank you.
Thank you,
There
sir,
are
for
any
the nice
questions?
presentation on a rather enigmatic topic. I would like to call upon our next speaker for the day, Dr. Pinak Das Gupta, Senior Consultant and Lead Colorectal Surgeon at GEM Hospital, Chennai, to deliver his talk on rectal prolapse.
Good afternoon, everyone who have joined us for this pelvic floor CME today. I am Dr. Pinak and I'll be speaking on rectal prolapse. So far we have already dealt with the anterior component by our urogynecologist madam and followed by urologist Dr. Rajshekhar. Now the third compartment is the rectal compartment. So in rectal prolapse, what happens is there is intussusception of the rectum. So it can be occult, which will be internal intussusception, or it can be an obvious visible rectal prolapse, which can be a mucosal prolapse or a full thickness rectal prolapse. Now in mucosal prolapse, there is only prolapse of the rectal mucosa. The muscles of the rectum remains intact. But in full thickness prolapse, even the muscles come out and it will be a thick prolapse. The pathophysiology of rectal prolapse is not very clear, though the factors which have been associated with rectal prolapse are constipation, mostly seen in old age group in the postmenopausal status, females. Previous anorectal surgeries, psychiatric illness and obstructed defecation have also been associated. If we look at the pathophysiology, there is chronic constipation along with straining, which leads to herniation of the rectum through the levator aperture of the pelvic floor. This leads to lengthening of the mesorectum and the attachment of the rectosigmoid, finally leading to a prolapse. So this is how complete procedentia looks like. If we look at the anatomical abnormalities, we find that there is a deep cul-de-sac associated with redundant rectosigmoid, an elongated mesorectum, diastasis of the pelvic floor or levator ani, and a dilated patulous anus. Coming to evaluation of rectal prolapse, clinical examination is of utmost importance as emphasized by the previous speakers also. So the anal tone, in the resting anal tone, the squeeze pressure and exertion on exertion, all the parameters of the anal tone has to be measured to find out if there is any lack of tone in the anal sphincters. This is to be aided by other investigations which are colonoscopy, because most of the times it happens in elderly age group and we should not miss out any growth or ulcer. And MRI difficography, if it is associated with some other compartmental symptoms of like incontinence or perineal descent or something, so that we can assess all the three compartments. And dynamic MR difficography is a very valuable tool in evaluating such patients. And to see the anal physiology, anorectal manometry is done. So already Dr. Sridhar has spoken regarding the pressure changes which you see in the anal manometry. So your clinical judgment will be aided by these evaluations, which will give you an objective evidence of the functioning of the anal physiology. There is no single perfect treatment for rectal prolapse, and many surgeries have been described. The approaches have been primarily abdominal and perineal approach. The abdominal approach can be in the form of a posterior mesh rectopexy or a ventral mesh rectopexy or suture rectopexy. Perineal approach, which is mostly done in those patients who have comorbidity and cannot be operated under general anesthesia, and also at times in young patients in whom since abdominal approach has an increased incidence of sexual dysfunction and autonomic nerve injury. So some of the proponents of perineal approach suggest that in very young patients, perineal approach should be preferred, which are the classical Thayer's procedure, which is very less often used nowadays because of complication and increased failure rate, and Delorme's procedure and Altmaier's procedure. Coming to the most commonly performed procedure for rectal prolapse, which is a laparoscopic mesh rectopexy. So this is how we position the patient, and this is preceded by a like preparation of the patient, which includes full mechanical bowel preparation and oral antibiotics plus parenteral antibiotics, and the procedure is carried under general anesthesia. So this is a procedure of posterior mesh rectopexy. You can appreciate the cul-de-sac, the sacral promontory, line of incision. These are the port positions. So we enter into the retrorectal space. This is the rectum. This is the presacral plane. So we have to be in the presacral Hawley plane, which is an avascular plane. This lateral dissection is followed by a limited anterior dissection to allow further take out the rectum from the pelvis. So this will allow the intersuscepted rectum to be out of the deep pelvis. So this is division of the septum. So you are separate. The rectum, anterior wall of the rectum is separated from the bladder, and this is followed by lateral dissection on the other side, and finally a mesh is placed according to the thickness of the rectum. Usually a 15 into 7 centimeter macroporous polypropylene is used. So this will induce fibrosis, and this will retain the rectum in the mobilized position. The mesh is secured on either side of the mesorectum, and finally the mesh is extraperitonealized. So posterior mesh rectopexy is one of the commonest procedure performed because of its ease of performance and lower morbidity and low recurrence, and significant improvement of continence is seen. Though the drawbacks of these procedures have been new onset constipation, which is seen in almost 53% of the patients. But the reason for this new onset constipation have been incriminated to the division of lateral ligaments. So now we have modified this procedure, and we try to preserve the lateral ligaments so that the constipation is less. In females, ventral mesh rectopexy is preferred because many times the anterior compartment is also involved. So, or anterior or the medial compartment problem also can be addressed while addressing the rectopexy. So this is a modified ventral mesh rectopexy where we, or the Orr-Lugay procedure, wherein both posterior and anterior mobilization of the rectum is done. this is the division of the rectovaginal septum. So here, anteriorly the vagina is there and posteriorly rectal wall is completely bared, and the dissection is carried out up to the perineal body, anteriorly and pelvic floor posteriorly. So once you have reached the lower limit of the dissection, the dissection is assessed. You can appreciate the preservation of the lateral ligaments and the dissection going up to the pelvic floor. Now the length of the mesh needed for the rectopexy is measured, and then it is sutured ventrally on the anterior surface of the rectum. The logic of suturing it to the anterior surface of the rectum is the anterior wall of the rectum is supposed to be the part which intercepts at the onset of rectal prolapse. Finally, the mesh is secured to the sacral promontory, and then similarly it is again extraperitonealized. So this completes the ventral mesh rectopexy. Complications, as with most other laparoscopic surgery, can be inadvertent enterotomy or a ureteral injury, organ injury during trocar placement, vascular injury, and the most say talked about complication is chances of injury to the autonomic plexus. Coming to the perineal procedures, this is Delorme's procedures, which includes mucosectomy. So the mucosa of the prolapsed part is excised. This is followed by plication of the muscular part of the rectum, and then again doing a anastomosis, mucosal anastomosis. Altmaire's procedures includes resection of the prolapsed rectum and part of sigmoid colon, redundant sigmoid colon if any, and an additional liveroplasty can also be done. So these are the perineal procedures. So once the procedure is done, since most of the rectal prolapse problem are associated with some sort of functional component, so biofeedback training is very essential. So this part of the procedure many a times surgeons forget, and that's the reason why increased recurrences are seen. So these patients need retraining of their bowel habit, and biofeedback is coming up in a strong way in follow-up of such patients. Thank you.
That was a crisp presentation in a most simplified way, sir, as always. Thank you very much. Our next speaker for the day, Dr. Kartika, consultant gynecologist and lead endogynecologic laparoscopic surgeon from GEM Hospital, Chennai, will be delivering a talk on the surgical management of uterine prolapse.
Thank you for the introduction, sir. Good evening, everyone. My topic for today is surgical management of pelvic organ prolapse. Pelvic organ prolapse includes descent of one or more of the following: either the anterior vaginal wall, posterior vaginal wall, uterus and cervix, the vault, and the perineum. It can occur in a combination of 2, 3, or many things combined, and the treatment is directed towards whatever is present in the patient. There are 4 stages of prolapse. The first 2 stages where the uterus is within the introitus, and the next 2 where it is outside the introitus. And surgery is usually done for the 3rd and 4th stage of prolapse. Before talking about the surgical management, we need to know the level of support of the uterus. The uterus has 3 supports. The first level of support is the cervix and the uterosacral ligament and the cardinal ligament, which is attached to the cervix. The second level of support is by the vesicovaginal fascia, anterior vaginal wall, and the rectovaginal septum, both of which go and get attached to the arcus tendinous fascia pelvis, thereby providing support to the vagina. Level 3 is the pelvic floor muscle, which is a perineal body, and level 3 is usually by wide introitus, and it is repaired by narrowing of the introitus and plicating the muscles. So reconstructive surgery is needed using a combination of procedures to correct the defects, and surgery can be vaginal, abdominal, or laparoscopic. So surgical treatment is based on the compartment of where prolapse is occurred. So it is directed towards anterior compartment, which is the cystocele repair, central compartment, which is the uterine prolapse or the vault prolapse, and posterior compartment includes the rectocele. Anterior compartment, we have the central cystocele and the lateral cystocele. Central cystocele or the anterior cystocele is a midline defect in the fibromuscular layer of the vagina. So that is treated by an anterior colporrhaphy, whereas a lateral cystocele or a paravaginal defect is due to detachment of the vagina from the arcus tendinous. So this is a picture of anterior colporrhaphy where an incision is made on the anterior vaginal wall and the bladder has been completely mobilized off the vagina and the vesicovaginal fascia is exposed. The plication of the vesicovaginal fascia is done and the redundant vaginal mucosa is excised and closed. In a paravaginal repair is almost similar to Bursch, as in we reinforce the vesicovaginal fascia and we try to approximate it to the arcus tendinous fascia pelvis. Sometimes we also take the bite in the Cooper's ligament because that's much more of a stronger ligament, but the lift is given only up to the level of arcus tendinous fascia. This is a picture of laparoscopic vaginal cystocele repair. We are able to see the arcus tendinous, the obturator internus, the Cooper's ligament, and the pubocervical fascia. This is, here we can see 2 stitches on either side where the lateral sulcus of the vagina has been supported and fixed to the Cooper's ligament. For the central compartment, the treatment of uterine prolapse or vault prolapse is again split into whether we want to, in a uterine prolapse, whether we want to save the uterus or not. In cases where we are planning a hysterectomy along, apical suspension needs to be done to correct the central defect. Vaginal hysterectomy with Mechal's scaldoplasty, where the vault is anchored with the uterosacral ligament, is the most commonest procedure that is done. The apex can also be fixed to other strong structures such as the sacrospinal ligament or the iliococcygeal ligament. A high uterosacral ligament fixation is also done. This is done, it's better done when it is done laparoscopically because of the view that we get of the uterosacral ligament, and it is plicated so that the vault is suspended well. This is a picture of sacrospinal ligament fixation of the vault. So sacrospinous ligament is also a very strong ligament, and the vault is fixed either on one side or on both sides. This can be done vaginally as well as laparoscopically. So when uterine preservation is required, we can either do a pectopexy, a sacrohystropexy, or a Fothergill's repair. The first two includes mesh. So a pectopexy is a condition where the anterior part of the cervix is anchored to the iliopectineal ligament using a mesh. And sacrohystropexy is when we use a mesh to anchor it to the sacral promontory, mostly the anterior longitudinal ligament of the sacral promontory. Fothergill's procedure is also done where the infravaginal, mostly it is done for patients who have uterine prolapse along with infravaginal elongation of cervix. This is done in women wanting to conserve the uterus but not wanting to bear further children. So the procedure includes cervical amputation, fixation of the Meckenrod's ligament to the anterior part of the cervix, anterior colporrhaphy, and DNC. Next we move on to vault prolapse. This is a picture of vault prolapse. And the gold standard management of vault prolapse is laparoscopic sacrocolpopexy. The next is a laparoscopic pectopexy. Again, the vault is suspended to the iliopectineal ligament on either side. Finally, the enterocele repair. For an enterocele repair, we usually do the Mechal's scaldoplasty where we obliterate the POD. It is done either vaginally or again laparoscopically. Posterior compartment repair includes posterior colporrhaphy, which is the plication of the rectovaginal fascia, which is similar to anterior colporrhaphy. In this picture, we can see the rectocele in the first picture. In the picture B, we can see that we have exposed the rectovaginal fascia and that we are plicating it. And finally, the vaginal mucosa is sutured. The last but important step is the level 3, which is the perineal repair. Here, initially, levator ani was, previously we used to approximate both the levator ani, but that is considered to be more painful. And approximation of bulbospongosis muscle and superficial transverse perineal muscle to form the bulk of the perineum is considered enough now, and to form the perineal body. So this procedure is also always combined in cases of where there is a level 3 defect. Coming on to obliterative procedures, in women, very old women, where we cannot go in for a hysterectomy and a prolonged procedure, we just obliterate, we can obliterate the vagina by creating raw surface on the anterior and posterior wall and approximating them. But this is done only in patients who are very morbid and where they do not want further sexual function. So finally, to conclude, management of prolapse is in identifying the defect and repairing the defect, but not hysterectomy alone. Thank you.
That was a very lucid presentation with excellent pictures. Thank you, ma'am, for that. Next, I would like to request Dr. Sendil Kumar Ganapati, sir, Senior Consultant Colorectal Surgeon at GEM Hospital, Coimbatore, to speak on biofeedback in pelvic floor disorders.
I thank Pinak for giving me the highest topic, and that too last in the session. Just 1 second. Now, are you able to see my screen?
No, sir.
No, not yet. Okay. Should be okay now, I think.
Yes.
Slideshow. So I'll stick to my topic, which is the biofeedback therapy, particularly in anorectal disorders. And this comes from GEM Hospital in Coimbatore. And the entire protocol and the results I will be discussing will all be the protocol followed at GEM Hospital Coimbatore and the results from patients of GEM Hospital Coimbatore. So what is biofeedback? We can call it as an operant conditioning, where we train a patient, we train like a group of muscles and announce rewards or announce punishment for certain activities, thereby strengthening the correct activities. You can also call it as a trial and error learning. But this trial and error learning is instrument based. And the instrument that can be used in biofeedback are mainly of two types. One is based on anorectal manometry, and the other one is electromyography. And the feedback which we give to the patient can either be in the form of visual, auditory, or verbal, or a combination of the three. So why at all somebody needs a biofeedback? So the stresses of the modern life, never-ending meetings, never-ending shifts where everybody waits to take a natural break almost at the end of the shift, after the end of the shift, and then usage of mobile phones where it shouldn't be, where the toilet is designed for a specific purpose, it is being used for other purposes like newspaper reading as well. So the pelvic floor, which is the subject of today's CME, is just like a hammock, which my former speakers have mentioned more than once, definitely, and they have discussed in detail as well. So I'll just keep it short about this pelvic floor. It is like a hammock through which three tubes are opening. So in the anterior compartment, it's the urethra, and in the middle, it's the vagina, and posteriorly it is the rectum. And I will stick to the biofeedback of the anorectal disorders. So the hammock has to be a smooth one for us to enjoy being seated or being lying down on the hammock. But, however, if it is a droopy pelvic floor hammock or a very taut pelvic floor hammock, we may not enjoy our time on the hammock. And that is exactly the case in patients who have either a droopy or a taut pelvic floor hammock, and they end up with a lot of problems, which has already been discussed. So what is the goal of biofeedback therapy? So it is basically to strengthen the muscles of the pelvic floor, improve the coordination. Particularly, we have the abdominal muscles, we have the pelvic floor muscles, the levator ani, the puborectalis, and the sphincter muscles as well. So all these have to act in a coordinated fashion in order for the defecation process to happen very smoothly. And also, the biofeedback can be useful in training or retraining the rectal sensation in both hyposensitivity of the rectum as well as hypersensitivity of the rectum. So how many times have we seen when somebody is tensed or is trying to rush through certain activities, they have to enter a building and they find the push sign on the door, but they tend to pull it, and if there is a pull sign, they tend to push it. So we have seen that so many times. That's exactly what happens when somebody is tensed. That is what happens with the anus as well. So when you want to open it, it is getting closed, and when you want to close it, it's getting open, leading to both the defecation dyssynergia, leading to ODS type constipation, and the incontinence. So what are the indications of biofeedback therapy? So the mainly 4 indications, among which the first 2 are the most commonly used indications, and particularly as we have started on with the biofeedback therapy in the last couple of years, I have taken up only the defecation dyssynergia and the fecal incontinence patients for the biofeedback. Biofeedback can be a little bit more complex with the functional anorectal pain and certain cases of irritable bowel syndrome, which I'm planning to take up in the future as well. So the manometry or the biofeedback which we perform at GEM Hospital Coimbatore is the anorectal manometry based. There are a lot of people who say that a learned finger can't say everything and they don't need a manometry, but does manometry make a difference about the learned finger? I think yes, the learned finger can do a lot of things, but yes, anal manometry can also add on to that by objectively assessing the sphincters. So we get the measurements, and particularly when we follow patients and when we measure the pressures, we will know whether the patient is improving or not improving. Yes, the rectal sensitivity can be assessed quantitatively using anorectal manometry. It helps to assess the rectoanal inhibitory reflex, which is particularly absent at Hirschsprung's, and yes, before and after surgery comparison. So we saw Pinnock presenting on the rectal prolapse. Of course, some of the rectal prolapse patients may have various type symptoms. Some may have, and more predominantly, it will be the incontinence type of symptoms. So if we measure the pressures before and after surgery, it gives us a measure of how much the surgery has helped. And of course, in terms of biofeedback therapy as well, Pinnock was mentioning about the biofeedback therapy after surgery, but the most ideally, it has to be started before surgery itself so that they get to know the correct way of the defecation, and then get the surgery done, and then follow it up post-operatively as well with a few sessions of biofeedback therapy, and that gives slightly better results. So the basics of anal manometry. So what do we see on the anal manometry screen? I'm showing this because this is exactly the screen which we get during biofeedback therapy as well. So basically, you can see that there is a pink zone, a black zone, and another pink zone down below. So this is basically the high pressure area of the anal canal. And if we measure these three zones, it gives us the functional length of the anal canal. And the green outside is the very low atmospheric pressure, and the green up is the very low rectal pressure at rest in a patient. And we use all these color codings. So we can, using the color codings, we can make the patient understand whether they are exerting too much pressure on any particular muscle. For example, in this patient, it's quite dark black, which means the resting pressure in this patient is quite high, and this is actually a patient who was having a fissure in anal, so hence anal sphincter. The equipment that we use for biofeedback therapy is almost exactly the same as anal manometry. We use a balloon catheter, and how we use it, I will be showing it to you. And water perfused tube, we use a 16-channel water perfused manometry system with a solid state micro transducer almost at the tip of the the catheter, which we insert into the anal canal, and that in fact each channel has a micro transducer attached to it, and it measures pressures to a larger area rather than a single point. So this is the balloon that we use. This has been inflated with about saline, and on the right hand side, gauge system where the water infusion system, and the syringe is used for blowing the balloon. And then the more closer look at the 16-channel water perfusion system, and the whole setup in the last picture, where the person doing the manometry or the biofeedback who's supervising sits here and then looks at the screen here, whereas the patient is sitting on the couch there, and there is another screen attached to the right in front of the patient, which the patient can see and follow our orders. The setup, this is how the patient is lying down in the left lateral position, right lateral position rather, with the screen right in front, with an adequate distance for them to visualize the screen clearly. And that is the patient monitor. They are seeing the pressure changes, and the pressure changes has to be explained by the biofeedback therapist to the patient, and that's the main monitor. And this is the software. The anal manometry needs a special software, and there is a small addition to the software, and we have a separate biofeedback software as well, where the percentage improvement can be calculated. So that's the biofeedback therapist who stands right behind the patient and shows the screen to the patient and shows the importance of the various colors, and explains and what exactly, for example, when they are squeezing the anus, how the pressure changes, and when they are relaxing the anus, how the pressure changes. And so based on the color codings, the patient can learn to get the right color on the screen. So in the first 1 or 2 attempts, the patient may not be successful, but almost all the time, after 4 or 5 attempts, if we ask them to relax, they are able to relax. If we ask them to contract, they are able to contract. So the whole setup was all started after my 1-week visit to the St. Mark's Hospital in London, where I was an observer at the Sir Alan Parkes Physiology Unit, one of the most famous anal physiology units in the world, and I was able to interact with some of the colorectal experts as well. And that was certification at the end of the 1 week of observership. So based on my visit and based on the literature evidence, we formalized a protocol. Always this begins with the assessment. The biofeedback doesn't straight away start in the anal manometry room, but it starts with the assessment in the outpatient clinic, where we do the basic investigations, and the anorectal manometry is also performed as an outpatient prior to our starting the biofeedback therapy. So I almost always don't start biofeedback therapy straight away, but always the start is after 2 weeks of education, patient education. So exactly based on the anal manometry and based on the symptoms, what exactly or the patient is doing that is getting them into trouble. For example, keeping the sphincters tight or not exerting adequate abdominal push, and that type of education. Um, and the dietary changes, probably they have been explained before, but I stress more on the high fiber intake and fluid intake as well. And then particularly lifestyle modifications. Almost always the patients, particularly with the odious type of symptoms coming for biofeedback, are almost always the stressed, anxious type of personalities who need quite a lot of relaxation. I ask them to do exercise or at least fast walking morning and evening, 1 hour each, or some yoga meditation techniques, or some sports activities as well. So whichever can take their attention from their work related stresses and family related stresses. Yeah, physical activity and using of the toilet stool can also be done in the toilet to convert the Western type of toilet into a slightly Indian toilet where they can exert a little bit more pressure onto the rectum and give it a little bit more push. And pharmacological therapy, of course, I start with some fiber laxatives like ispadura, husk, or go to a slightly or a combination like a fiber lactose. And then if that was something like added on to it, like a stomach laxative, like adding sodium glucosylate. And if that doesn't work either, go for PEG combined with sodium glucosylate. So there is, and then if there is an element of slow transit constipation as well, then start them on some protopride as well. So that's the pharmacological therapy, which in most of these patients are tried and tested, and where they may say marginal improvement or no improvement. Of course, we have to continue with all these things as well if they are started on biofeedback therapy. Starting a biofeedback therapy doesn't mean that they can forget all these things which I have said. And then our protocol is ARM based, 4 sessions, a weekly 1 session, and 1 hour per session. And the indications we are taking currently are the dyssynergic defecation and fecal incontinence. So what exactly are the components that we do during biofeedback therapy? What do we do in that group? So based on the pressure measurements, we can tell whether the patient is giving an adequate abdominal push effort or not. And then when we first start to ask the patient to give a good abdominal push effort, a lot of times what they do is tightening more of the anal sphincters. And then after 2 or 3 failures, and then they slowly start getting where they have to make a push and they contract the abdominal muscles, and we can directly see that result by an increase in the rectal pressure. So yes, we concentrate. The first thing we concentrate on is the abdominal push effort, and then recto-anal coordination. So whenever the abdominal muscles are being contracted for the purpose of defecation, the sphincters have to be relaxed. There are different types of dyssynergic defecation, which Sridhar was mentioning earlier, where there is no coordination. If there isn't adequate abdominal push, and if the sphincters are too tight, nothing happens. So only when the adequate abdominal push is there and the sphincters relax and open up the anal canal, only then the defecation process happens. a simulated defecation, we do that by putting a balloon and about 40 to 50 ml of saline is infused into the balloon, and we ask them to defecate. In woodiest type of patients, usually they take more than 1 minute to expel the balloon. Then rectal sensory training. Rectal sensation is assessed by the amount of inflation up to which the patient gets discomfort or gets the urge to urinate or gets the pain. So we can find out whether the rectal sensation is less or more hyposensitive or hypersensitive. And based on that, we can, for example, if the patient is only responding to the hypersensitivity, if they are responding only to a balloon of 200 ml, then initially we go up to 200 ml and then bring down to 180, 190, 180, and then they start feeling when the small decreases or so similarly with hypersensitivities. So what do we do in patients with fecal incontinence? When I mean incontinence, yes, a lot of patients are incontinent with a torn off sphincter, which needs a surgical repair. In those kind of situations, whatever remaining sphincter, we can make them work by doing biofeedback therapy to recruit whatever muscles they have left and get them to work before we do the surgery. And then after sphincter repair as well, after wound healing, they can be retrained as well. So in those kind of patients, the surgical treatment becomes more important. But there are a lot of patients who have incontinence, but it is a kind of urge incontinence. A lot of patients with IBS we see with urge incontinence. So the patients say that when you measure the anal manometry, then they have like normal pressures or increased pressures, but it is the situation when they get the urge to defecate because of the hypersensitivity of the rectum, the automatically, even though the muscles are normal, the anal sphincter relaxes and some leakage happens. So these are the kind of incontinence patients who respond very well to biofeedback therapy, sensory training. And once again, the balloon holding, even for those with a very weak sphincter, we can put the balloon inside, ask them to contract the muscles as much as they can and give a tug on the balloon and make them hold the balloon as long as they can within the rectum. This last maneuver appears to be working very well with the patients with incontinence with a partial sphincter tear. So our results are total patients who were referred from the outpatients for biofeedback therapy were 68, but some exclusions happened, and yes, I had to exclude a few patients as well because there are certain patients where the main component is a slow transit type of constipation, or main component is IBS constipation type, where they won't respond to biofeedback therapy. So after exclusion, totally we did 52 patients, among which 39 were females with a mean age of 52.6 years. And the indication was more in favor of dysynergic defecation, and 17 patients with a fecal incontinence. So in this fecal incontinence, I included the patients with a fecal urge incontinence as well. So how many sessions are they attending? So what we advise is that everybody has to undergo 4 sessions, but only about 10 patients completed all the 4 sessions, whereas predominantly they have done 2 or 3 sessions. The problem is they come from far off places. GEM Coimbatore is a tertiary referral center, and patients with this kind of constipation have seen a lot of people locally, and then they finally come to a tertiary center here, and then they have to go to therapy because they come from far off places. Not everybody is able to make it for 4 sessions in a row every week, and that's the problem with the completion of the sessions. Low complaints, why tertiary referral center? If they have even a marginal improvement of symptoms, they think that they don't think about reinforcing the improvement, but rather with the marginal improvement gained, so they stop managing their life like that. And currently, I'm able to offer it only 2 days a week, and that is another reason for us. results, so overall response rate 75%. So basically 75% improvement we can see. So this improvement can range from marginal improvement to significant improvement. When we predominantly most of these patients show improvement with both symptoms and in the measurement of the anorectal manometry pressures. So this goes on to say that for small changes, it's not just that only big changes can make a big difference. A lot of times, small changes can make a huge difference as well. Why I'm saying this, because I have seen that right in front of my eyes with some of the incontinent patients who had come to me for biofeedback therapy. For example, in the initial session, the balloon holding time was like 5 seconds, and they could not reach the toilet and they leave. Whereas the balloon holding time, when it was increased to when there was an improvement of 5 seconds, when they reached 10 seconds, and some of them when they reached 15 seconds, it meant that to see it as only a marginal improvement of 5 or 10 seconds. But then if they are within the house, they are able to make it to the toilet. It makes the difference whether they are able to make it to the toilet or not. So that makes a huge difference for the patient. So yes, these are small changes we do with biofeedback therapy make a big difference. And in conclusion, colleagues, PFT is an established treatment nowadays. Yes, the treatment is established, but the protocol is not still properly established. Different institutes work on different treatment protocols which suit them. Yes, standard protocol need to be established, and it does need periodic reinforcement. The problem is when they are out of stress, they might come out with a permanent problem permanently. But however, a lot of patients, if they have a periodic reinforcement for, like, for example, after 6 months, after 1 year, then they even better results can be obtained. And I don't think anybody can doubt on the safety of this biofeedback therapy. I haven't had any significant complications, or I can confidently say there was no complications at all during this therapy. Thank you very much for this opportunity. And that was the presentation of this biofeedback, our protocol, our results of the AccuracyCon in 2018, and that was it's 19. Yes, it was 2019, and yeah, Dr. Despi. Thank you.
That was an eye-opening presentation on a topic that most of us are oblivious to, sir. Thank you very much. And with this, our session on lectures have come to an end. We will have a concluding exciting video presentation by Dr. S. Rajapandian, sir, the head of colorectal surgery department at GEM Coimbatore.
பசுபதி இப்போ வந்துருச்சா? தெரியுதா? ஸ்க்ரீன்ல இப்போ ஷேர் பண்ணுவாங்க. Okay. Now we- okay. Am I audible and visible now?
Yes, sir.
Okay. Good afternoon, everybody. Thank you, Pinak, for the opportunity in this CME. And I really appreciate all the speakers who has given a nice talk about the pelvic floor disorders. And Senthil Ganapathy has clearly mentioned about the usefulness of biofeedback in the anorectal disorders. I think most of nearly 80% of these disorders, particularly anorectal disorders, can be managed by biofeedback. Very little, probably less than 10% or 20% will end up in doing some surgical correction, particularly if there is any defect. So just as a completion, just I want to show what we have done in GEM Hospital, Coimbatore so far for the pelvic floor disorders, particularly the sphincter repair. So which is very most commonly we come across, particularly the obstetric injury. I think Karthika as the gynecologist must be knowing. Yeah, last year, the single month, we come across three different type of perineal injury following obstetric, following labor. Particularly type 3 and type 4 injury, you need a proper repair, otherwise the patient will end up in permanent fecal incontinence. So I'm just going to show the videos of how to have a anal sphincter repair. Mostly the indication, most of this will be obstetric injury, of course, following fistula surgery also will be there, post-trauma injury or post-operative or iatrogenic. So just a few points before going to the surgery, just I want to mention this, though it has been mentioned by the previous speakers by the skeletal muscle can tear when it stretches beyond 150%. There is any skeletal muscle. But in labor, you can see up to 250 percentage, there will be a stretch in the pelvic floor muscle. So that's why it end up in perineal tear. So this is the perineal muscles you should keep in mind while you are repairing. This is the superficial transverse perineal as well as the deep transverse perineal muscles. And this is the bulbocavernous muscle, and this is the external sphincter, and internal will be the internal sphincter. So internal sphincter is nothing but condensation of the circular fibers, and the external anal sphincter separately will have a superficial, subcutaneous, superficial, and deep part. And deep part will be merged with the puborectalis. And we should know that the resting anal tone is given by 30% by the voluntary, that is the external sphincter, whereas 70% of the resting anal tone is by the internal sphincter, which is involuntary. So this is the picture explaining the various perineal tear during labor. So whenever there is a perineal tear of 1 and 2, that can be managed nicely by the gynecologist. When there is a perineal tear, which is 3rd degree, which includes the anal sphincter, whether it's more than 50% or less than 50%, then it should be corrected properly now and then. Otherwise, there will be delayed repair. Most of the patients, they have come with the anovaginal or rectovaginal fistula passing motion through the vagina, which is very, very hard to accept for a young female just because she has given birth to baby. So the main thing we used to do investigation is the manual manometer to look for the strength of the sphincter. As Senthil Ganapathy has nicely mentioned, we can clearly know what percentage, rather than by doing a rectal examination, anometric correctly will give how much. And trust is very important where there is a sphincter defect is there between 12 to 11 o'clock or more. Of course, you can be explained with the it's shattered, then you may need a help with the MRI pelvis. So this is just a small video showing this is a 24-hour lady who has given birth just 8 months before with the type 3B perineal tear. So there was, after investigation, we found there was a defect there between 2 to 11 o'clock position in the sphincter, both internal and external sphincter. So we just make a curvilinear incision and try to dissect the skin and subcutaneous from the muscle so that we can extend. So you can see the muscle is the part. So there is a defect between the 11 and 12 o'clock. So we try to dissect the muscle. So in between the scar tissue, you should not excise the whole scar tissue. You can just divide and make sure whether we can have a overlap sphincteroplasty. Sometimes overlap sphincteroplasty may not be have enough to have enough muscle. There will be loss of muscle tissue. In that case, we can't do overlap sphincteroplasty. So in this case, I would be able to dissect the muscle to have overlap sphincteroplasty, since the defect is not in a clear section. So in a disorganized manner, so now and then we have to repair the muscle both transversely as well as longitudinally. So you should not go very deep in 9 o'clock and this side 3 o'clock position, so that because you don't want to injure the pudendal nerve supply to the muscle. So even if there is injury, then once you make overlap sphincteroplasty, the scar tissue will be helpful in holding the anal canal tone. As then post-operatively, once it has healed, we can have a biofeedback therapy, and we can make the patient guide them to have a normal anal continence. So here we are just making with the non-observable suture with the mattress, that is horizontal mattress, then overlap with the simple sutures. So in case if the muscles, that is the sphincter muscle, you could not have overlap, that is then we can have various other method. That's Kalakar special suture method. Special suture is called Kalakar suture, where you can have a intracted suture with the non-observable suture material. So now once the overlap sphincteroplasty is finished, once you complete the muscle repair, then we have to close the skin and subcutaneous in the vertical manner. Once we have made a horizontal, so now we have to close vertically with the mattress, vertical mattress. So this patient went without any diversion. She was still complaining for the past 2 years. She has a very good anal continence now. So this is another which just shows where you don't have a overlap sphincteroplasty. Instead of that, we can have a palette suture technique, where you have take a non-observable suture, interrupted, so without destroying the blood supply to the sphincter muscle. So we have to delineate the skin subcutaneous and dissect the muscles from the skin and subcutaneous tissue. The scar tissue will be making very difficult to delineate the muscle. We'll try to delineate without making a hole in the skin. Sometimes the scar tissue have to be divided, but we should not excise more scar tissue. So we have to keep it so that we can have enough tissue to close the rent. But always you should keep one index finger or little finger in the anus, so that you should not completely close the anal canal. So this dissection on the left lateral aspect of the lesion. On either side we have the dissection. Once we don't have enough length of the muscle to have a overlap sphincteroplasty, in that case we can have so we try to dissect the external sphincter separately and internal sphincter, but most of the time you will not come out. Here you can't do overlap, so just we are going to approximate with a special suture that's called first before opening just one initial, just to close the skin. So we try to, if possible, we can differentiate the external and internal sphincter, but most of the time you will not be able to differentiate. You will be losing more, and there may be loss of muscle as well, or we may be doing more, we may traumatize the muscle. So this is out in, then out in from opposite. So by taking a suture like this, we will not do it. Now in out, So where we can't do overlap sphincteroplasty, we can just approximate it, then in out. So this way we can just approximate the end so that will not traumatize the muscle as well, and we will approximate nicely. So like interrupted, we have to do like this. After suturing, just cut it and close the skin. So simple suture just overlapping the sphincters. So all these patients went without any diversion, but we have other patients who have extensive soiling and severe anovaginal, rectovaginal fistula. We have to divert the patient after nearly 6 months. Once the sphincter control is okay and there is no any rent, then we have closed the colostrum. So sphincteroplasty is a safe procedure, so it's a precise operative evaluation is mandatory, and medical surgery should be performed to be successful. So just I would like to show another video. This is just what the gynecologist and the Karthik has mentioned for the that is for urinary incontinence, the stress urinary incontinence. Usually the standoff procedure is bus corpus infection or TBT. So this is one of the earliest which we do in the extraperitoneal approach. This is a laparoscopic retropubic fixation, that is retropubic with urethral fixation to prevent the stress urinary incontinence. This is the extraperitoneal approach. We are going extraperitoneally, making enter the extraperitoneal space. This is the lens strip Procard method. We just make a subumbilical incision. We have entered the extraperitoneal space. We retract it.
Sir, video player.
ஆகலையா இங்க ஆயிட்டு இருக்கேன். ஹலோ இப்போ ஆகலையா? ஓ ஓ அப்படி ஷேர் பண்ணு. ஓகே ஓகே ஓகே. அப்போ அதை ஆஃப் பண்ணிட்டு இதை ஷேர் பண்ணுமா? இப்போ ஷேர் ஸ்க்ரீன் போடுங்கண்ணா. வந்துருச்சா?
Okay.
Okay. This is one of the earliest to do extraperitoneal Birch-Calpo suspension for stress urinary incontinence in a young female patient. So we have, doing the subumbilical incision, we have entered the extraorbital space using lens-tube Proctor method. We are just, once the gas is inflated to 12 to 14 millimeter of mercury, we are using a zero-ring telescope to create the extraorbital space. You can see the inferior epigastric vessel. This is the routine way of create for our TEP repair. So we are making the right hand working trocar. So just cauterize these tiny vessels to further to increase the extraorbital space. So there will be anterior posterior and now transversal fascia just below. Now we are identifying the pubic symphysis and superior pubic ramus. That is the Cooper's ligament. So our aim is to now create the space for the left hand working trocar. So just dissecting the midline. So we can see the pubic symphysis, pubic ramus. And we use the Cooper's ligament. So we are creating the retropubic space of Ritchius. So finding the arcus tendinous. So dissecting the bladder neck. So at the urethrovesical junction. So that is the arcus tendinous, this is the arcutus internus. Then make a stitch from the Cooper's ligament to the arcus tendinous. Make a sling. So on either side too. So that is the para-uterus space. We have entered the para-uterus space. So I'm using a 10 polypropylene poly. Taking stitch the arcus tendinous and another stitch on the Cooper's ligament. You should not tighten, that is, this will decide about the importance post-operatively. You should not make it more tighten as well. So the gynecologist from the vaginal aspect, they are guiding us to take a proper stitch at the upper part of the vagina. So on either side, 2 stitches enough to lift the vesico-ureteric junction. So make sure they should not go very near the urethra and they should not close it. So that's all. And next I will show the laparoscopic management of high rectovaginal fistula. Kasubane தெரியுதா? Hello?
ஓகேங்க சார், ஓகே, ஸ்லைட் தெரியுதுங்க சார்.
Okay. Just as a last that just what is the patient following orthotic injury or following pelvic surgery, many patients may end up having a vaginal fistula. Most of them they will have a low rectal vagina, a high rectal vaginal fistula. I'm not going to detail about this because already they have all mentioned. But most of the etiology constitutes the obstetric trauma, because of the episiotomy, other factors, the Crohn's or malignant disorders of cervix, rectum, or following radiation therapy. So less common causes are the fecal infection and other infections. So mostly they will have their foul-smelling vaginal discharge. So rectovaginal fistula can be classified as low, mid, and high. So I'm just going to talk about the high because low and mid will be managed by the perineum through perineal approaches. And for diagnosis, so you should have taken a sigmoidoscopy or vaginography or usually MRI pelvis and do a vaginogram. You can have the diagnosis, but you have to do the sigmoidoscopy, make sure there is nothing anxiety or anything. Patients, even though patients have a previous history of surgery or obstetric trauma. The timing of surgery is very important for rectovaginal fistula, particularly high rectovaginal fistula. Immediate as a second paper, usually they will be having after 3 to 6 months to wait corresponding case in case of obstetric trauma. But in case of post-operative, mostly we have to wait for minimum 6 months. So these are the other surgical approach for low and mid fistula, a transanal approach or perineal approach or vaginal approach. For high rectovaginal fistula, I'm not going to detail about this small ones. First, I'll go to the video. The high, this is a patient as a 40-year-old lady who underwent immediate 1 year before, diagnosed as high rectovaginal fistula with a vaginogram showing the contrast imprint from the rectum there. So MRI pelvis shows there is a vent in the vagina and communicating between the rectum. And patient position is like this in the semi-recurrent position, in the fourth placement, like any other pelvic surgery. So first assessing the, there will be huge adhesions in the pelvis because of the infection. So we have to do adhesiolysis, remove all the small bowel adherent to the pelvis. Previous pelvic surgery, this is the previous hysterectomy. So then we have to delineate the rectum and the fistula tract. So first the adhesion to the wall there is dissected out. So I'm trying to delineate the rectum. Now the wall has been delineated, then just with the help of gynecology, going to the CCL retractor to lift the valve, and we can make a vent under the valve so that we can delineate the fistula clearly. Now we are just opening, now delineating the valve and the rectum in the positive aspect. So valve, the CCL retractor is seen. So we are just opening the vaginal valve distal to the fistula. You can see the fistula opening there. So then we have to dissect the rectum after disconnecting the fistula tract from the vaginal wall. So here you can see the fistula tract from the vaginal wall, and we are separating the rectum from the vaginal wall after accessing the fistula. Now you can see the fistula clearly from the rectum and the vaginal wall. So once separated the rectum from the vaginal wall, dissected, we have to close the wall first. Using 20 PDS and just closing the wall. So once vault is closed, then we have to close the rectum actually in a transverse manner so that there will not be this picture formation. And we'll keep momentum in between so that there will not. So now we are trimming the edges of the rectal mucosa and the rectal wall. All the diseased part and the granulation tissue will be excised so that there will be nice approximation based picture formation. So you can see we have to close it transversely to prevent any picture formation. So use 2 PDS, interrupted mirror, full thickness. So once you close it, we can just do a air leak test by injecting air and keeping the saline in the pelvis. So if there is improved no air leak, here we can come with a diversion, but in this case, we diverted the diversion diastole vascular. The standard we use always diversion diastole because now this is the disease part, we don't know if there is a leak, then again there will be a problem. But if you feel it is very healthy, nicely approximated rectum, there is air leak test is negative, I think now we are doing air leak test with monitor. So then we keep vascularized momentum in between the valve and the rectum, which is a suture, so that to prevent further formation of the cracks. And just make a one stitch so that it's going. So this patient actually the diversion is just coming. But if you feel there is a healthy approximation of the rectum and there is no leak in the leak test, I think you can without the diversion. So that the patient will not be the students. So this patient, so we wanted to keep a drain of the pelvis and the diversion. Okay, thank you with this. So with this, my talk ends. Thank you for the patient listening. Anybody, any question?
Sir, conclude பண்ணிக்கலாம்.
Anvita.
conclude பண்ணிக்கலாம்.
Okay, with this we conclude our program, CME program today. Thank you, Pinak. Pinak, is there, you want to talk anything? If there is any question, we can post to the GEM Hospital website. We'll be happy to answer. And I thank all the participants and all these speakers who have given nice talk today. Thank you very much.
சொல்லிட்டு வந்துடுறேன்.